Um, and now we're live. Good morning, dear scientific community. I'm here on behalf of Ukrainian Swiss Project Medical Education Development. Really glad to welcome you on our retreat for researchers. Today and tomorrow is a reward for you for the quite a challenging past 6-8 months that you were doing this. You had plenty of mentoring session, you were doing your research, and today you get in like to the almost to the final. Today we're gonna hear your presentations of your scientific outputs, and this is for us quite celebrating and festive moment. Today, we're gonna have a plenary session first with Dr. Groot. And after the plenary, we will hear out your presentations for the technicalities. You will have up to 15 minutes for the presentation, and then we will have Q&A and feedback from the supervisors that we're gonna have online, and for the Q&A from the audience here. In case of air raid alarm, we will look out for the threats, and we will monitor like how dangerous the situation is. If we have a confirmation that is either, I don't know, strategic jets flying or something, we will go downstairs to the shelter. If the alarm is, I don't know, low level risk or something like that, we will stay here in the audience, if that's okay with you. I guess from all the organization moment, that's it. If you have any other questions, so our event is will be held mostly in English, but there will be some sessions in Ukrainian. Feel free to have, I don't know, to ask to clarify anything you would like to. That's probably it. Yeah, I hope like this. I know that you a bit stressed before the presentation, and you would like to have it done right away, and then forget about the research that you've done. But we're doing this not because we like you to suffer. We're doing this because we have to have this retreat held in this growth and motivating manner. So we will have not only celebration of your scientific outputs, but also we'll have some activities to help you develop better communication skills. And so more people will find out about the findings of the researches that you've done or you will do in the future. Having said that, we'll not take any more time from our distinguished guest from Maastricht University. It's Groot, Professor of Health Economics of Maastricht University. Wim, the floor is yours.
Thank you, Victor, for your kind words of introduction. Good morning, everyone. It's a great pleasure to be here again in this beautiful city of Lviv, and especially in this week that marks some very important occasions. Not only is it on Monday, the 27th, exactly 9 years ago, that the Russians invaded the Crimea and occupied Simferopol, and of course on Friday, it's 1 year ago that the Russians fully invaded Ukraine. That's not the reasons why we're here, although it's good to, I think, to keep it in mind. As also what we do in this Swiss project on medical education reforms is part of an effort to improve the resilience of the healthcare sector and to make it adaptable to change and reform that are so much needed here in the Ukraine. Now, the important occasion to mark is that we This is well, a highlight in the project that, as Victor mentioned, we started 7-8 months ago in the research projects which we collaborated upon, and of which the results will be presented today and tomorrow. Of course, not all papers are yet fully finalized. We plan to do so in the weeks and the months to come, to bring it to a publication, at least to a paper that is ready for submission to a peer-reviewed academic journal. Now, in my lecture this morning, I want to touch upon some other developments in healthcare, namely the move towards value-based healthcare. And in my presentation, I want to take you through some of the things that, at least in my perception, are important for reforms of the healthcare sector worldwide, and which may also be relevant for the continuous reform of the healthcare sector here in the Ukraine. To introduce this, I want to draw your attention to this graph that I've taken from an OECD publication, Health at a Glance, which sets out healthcare spending per head of the population in various countries in the world, and life expectancy in years. I think the main outcome of what we do in the healthcare sector, namely to improve and increase life expectancy of the population. What this graph quite nicely shows is that there is a positive relation between how much countries spend on healthcare and its main outcome, life expectancy. So it seems that we get value for money in the healthcare system. However, if you, what is also obvious from this graph is that the more countries spend on their healthcare system, the lower the added value of the healthcare system becomes. If you look at countries with lower levels of spending, say between $1,000 and $2,000 per head of the population, we see that the increase in life expectancy is close to 1 year. That can be added to your life expectancy. If you look at high spending countries, the countries that spend between $4,000 and $5,000 per person on healthcare, you see that the increase in life expectancy is much smaller. It's more in the vicinity of about half a year of extra life expectancy. Now, so the question is, why is it that we see these, what economists call diminishing returns on investment in healthcare spending? Now, I think there are a couple of reasons for that. That also have to do with the reforms and the shift in focus in healthcare systems around the world. The first, and I think maybe the most important, is the trade-off between life expectancy and quality of life. What you see, and I will show some figures in a minute, is that when countries move to higher spending levels, that they allocate relatively more of these extra spending on interventions that not so much increase life expectancy, but rather improve quality of life. And that there is a shift in preference from improving life expectancy to improving quality of life of patients or population at large. Secondly, I think a second main explanation is that the diminishing returns signal increased inefficiency in the healthcare spending. Some of the countries, especially the United States, that was on the previous graph, they have a problem with a high number of people, a relatively large share of people without health insurance, have problems with fragmented systems. I think also that is something you see in some other high-spending countries as well, that the system is highly fragmented with quite a lot of bureaucratic costs or administrative costs because of this fragmentation in the system. A lack of a well-developed primary care system. One of the, I think, main insights from health economics is that a well-developed primary care system can is efficient in the sense that at low cost it can treat quite a lot of patients and prevents the patients from using more costly forms of hospital care. And finally, in mostly of these fragmented systems without a well-developed primary care system, you see an overuse of more costly forms of healthcare like emergency care in hospitals. So I think there are two main reasons. The shift from improving longer living to more quality of life and increased inefficiency in the system. If you look at this shift in priorities in the healthcare system, I think there are numbers of trends to be distinguished. One is that with the shift from infectious diseases to more chronic diseases, that is also caused by a change towards more lifestyle-related causes of illness and mortality. And that has, you see, gradually led to a change from a focus on whether diseases are treatable to whether diseases are also preventable by taking preventive measures both within the healthcare system when it comes, for example, to vaccination, but also in medical use, like medication use that addresses the adverse effects of an unhealthy lifestyle, to direct lifestyle interventions to stimulate that people lead a more healthier life and thereby prevent chronic diseases from onsetting. So we also see a more attention being paid to prevention rather than to treatment. And as I said, we see in countries a shift to that not everything is being done to extend people's life expectancy, but that also the impact on quality of life is taken into account, and especially in cases where there is a trade-off between extending life expectancy by doing invasive medical treatment on the one hand, and the impact on on quality of life for the remaining of the life expectancy on the other hand. And finally, and that is also related to this trade-off between life expectancy and quality of life, the voice of patients themselves is taken more into account, and it's more the patient himself who decides whether everything that is medically, technologically possible is being used to improve life expectancy, or rather that the quality of life is more taken into account. And that is part of what we call shared decision making between the physician and the patient, and the move from physician-centered care to patient-centered care based on the priorities and the values that patients have. And that also, I think, has implications for the way that we have organized our healthcare system, because it also means that we have to move our remuneration system from a system that is focused on remunerating physicians for what they do, for the time and effort that is spent on patients by, for example, fee-for-services forms of patients, to payment systems that reward physicians for what they do for patients. And that I will talk to in a minute when it comes to value-based healthcare. Now, just to illustrate some of the things that I've just mentioned, this again is a graph from the OECD statistics, Health at a Glance, which shows the mortality rate, that can be attributed to treatable causes and the mortality that can be attributed to preventable causes of death. And there you see, if you look on the right side, the mortality due to treatable causes of mortality, that to begin with, that within the European Union, there's quite a variation in treatable causes of mortality. The best performing country here is Sweden, where only 60 out of the 100,000 in the population die from treatable causes of death, as opposed to, for example, Romania, which is on the bottom among the EU 27 countries, where 208 out of 100,000 people die from treatable causes of death. That is more than the threefold difference between the best and the worst performing country within the European Union. Now, if you look at the best performing countries in preventing treatable causes of mortality, then you see that these countries not necessarily also do equally well in preventable causes of death. Again, look at Sweden. We see that Sweden is there's more preventable causes of death than people die from treatable causes of death. And more in general, we see that almost all countries, that the number of people that die from things that could have been prevented is higher than what people who die from treatment. Now, the main message, I think, to draw from this is that, well, European countries have well-developed, well-functioning healthcare systems, which to a larger or smaller extent are able to prevent treatable causes of death, but they are much less well-performing in preventing preventable causes of death, and that more people die from that than from treatable causes of death. And that warrants, I think, also more emphasis on prevention rather than on the healthcare system itself. So more attention to prevention. The other the trend that I mentioned, the move towards more quality of life, is, I think, well illustrated by this graph, which shows the breakdown of healthcare spending by different functions of the healthcare system, again for the EU 27 countries. What is striking here is the large heterogeneity between countries in Europe in the share of the total healthcare spending spent on measures to improve mortality, to improve life expectancy, mainly, of course, through inpatient and outpatient care, and the share of resources spent on improving quality of life, mostly by long-term care, LTC in this graph. Take, for example, on the one hand, a country like Italy. Italy, of its total healthcare spending, spends only 10% on measures that are mostly focused on improving quality of life through long-term care on the one hand, and a country like the Netherlands, which spends close to, or Norway, which spends close to 30% of its total healthcare spending on long-term care to improve quality of life. Of course, the other side of the coin on this is that a country like Italy spends more than 60% on inpatient and outpatient care, whereas in countries like the Netherlands and Norway, that is less than 55% of total healthcare spending. And that signifies the differences in preferences, relative preferences between countries in the measures to increase life expectancy, on the one hand, and countries that emphasize more quality of life on the other hand. However, if you look over time, I think all European countries have seen an increase in the share of their healthcare spending that they spend on measures to improve quality of life. Another way of looking at it is to look at where does the growth in healthcare spending go to. This shows the growth in healthcare spending in the period 2013-2019 and in the years 2019-2020 on some separate functions. There you see, well, for all types of medical care or healthcare, growth in healthcare spending was higher in 2019-2020, but you see also some differences in growth rates, with the highest growth rate in preventive measures. That also had to do with the COVID epidemic in 2020, which led to more investments in prevention, but also in the period before you see that growth in spending on preventive measures was higher than average. And on a second thing to observe is that also the growth in long-term care spending was higher than, for example, the growth, at least in the period 2013-2019, in inpatient and outpatient care spending. So also this shows the shift in priorities, in preferences within the healthcare system. Of course, we still have to keep in mind that when it comes to prevention, that a relatively small share of total healthcare spending is on prevention. That is illustrated by this graph, where you see that still not more than, say, 3 to 4% of total healthcare spending is on prevention. Although you also have to keep in mind this is prevention that is within the healthcare system itself. A lot of prevention, of course, takes place outside the healthcare system. For example, in fiscal measures to discourage people from smoking or drinking, extra taxation on cigarettes and alcohol, measures to make the environment more safe, including measures to reduce levels of pollution, air pollution, or measures to make mobility, traffic more safe for people. These are also major investments in prevention that are not shown up in the amount of money that we spend on prevention within the healthcare system. So that I think illustrates the move towards more prevention, the move towards more emphasis on quality of life, that are illustrative for the way the current trends in healthcare systems around the world. The other, I think, trend is within the healthcare system is on improving efficiency within the system and also to make the system more patient-centered rather than physician-centered. And I think a major impetus for that has been the book by Michael Porter and Elizabeth Iceberg titled Redefining Healthcare from 2006, in which they said, well, that the healthcare system and their focus was mostly, as Americans, on the US healthcare system, suffered from large inefficiencies, mainly due to overtreatment and practice variation. They said that they illustrate, and I'll show some figures on that in a minute for European healthcare systems as well. There's a huge practice variation within the healthcare system, where some physicians, some hospitals produce some forms of treatment much more frequently than others, given the composition of the patient population. And that as a result of that, those centers, those physicians that perform certain interventions more frequently than others, engage in over-treatment of patients. And over-treatment of patients is harmful for patients, on the one hand, because we know that every form of medical intervention carries a health risk to them. That avoidable harm is being done because of the treatment that the patient receives. And on the other hand, of course, over-treatment of patients is costly for the healthcare system, makes that the cost for the taxpayer or the insurance is higher than is actually needed. So it's both inefficient and harmful for patients if unnecessary treatment or over-treatment is provided to patients. And what they aimed for in this paper or in this book is to see what measures could be taken to reduce over-treatment of patients and reduce practice variation within the healthcare system. And they say that you can best do that by putting the patient at the center of the whole system. Now, just to illustrate this, what they argue in this book about practice variation, this is some findings from a study conducted in the Netherlands, which looked at the degree of regional variation between regional hospitals in the treatment of lung cancer patients. And they distinguish in between different forms of treatment, radiotherapy, chemotherapy, CT scans, ER contacts, and hospital admissions. And then they looked at the variation between the hospitals that performed these interventions, these forms of treatment most frequently, compared to hospitals that perform these forms of treatment least frequently for 3 years, 2013, 14, and 15. And what you see, if you look at the columns, the factor scores, there you see that, for example, for radiotherapy in 2013, the difference between the highest performing regions and the lowest performing regions, and the 5% highest performing regions and the 5% lowest performing regions, was 3.2, meaning that in the 5% in hospitals where radiotherapy was performed most frequently, this was more than 3 times more frequently than in the hospitals where the radiotherapy was done least frequently. Now you see that for the other the forms of treatment, the scores is around 2, meaning there's a twofold difference between, say, the most frequent providers and the least frequent providers. Now, this shows that, of course, there may be some difference, of course, in the incidence of lung cancer between regions, mostly because of social economic differences and environmental issues, but still it remains that there's quite a lot of, even within a small, rather homogeneous country as the Netherlands, quite a lot of practice variation in the treatment of, in this case, lung cancer patients, and yeah, that this holds for most other forms of treatment as well. Is this correlated with some other forms of treatment? Do you see differences in treatment path? So in the integrated form, if you look at more integrated way at the treatment that patients receive, and the answer is rather no. This table shows the correlation between these different forms of treatment and some outpatient forms of treatment, like the number of GP home visits, the number of GP consultations, the number of home nursing hours, and the number of activity of daily living, more caring form of hours. And there you see that most of them, these correlation coefficients, are small and statistically non-significant. The only one where you see some significant correlation is between the length of stay in hospital, hospital admission days, and the number of GP home visits. And there seems to be a trade-off between that. If patients have a shorter stay in hospital, then it's more likely that they will receive GP home visits in that. So there's a negative correlation between these two. But for most of the other correlations between inpatient care and outpatient care for lung cancer patients, there seems to be no correlation, no association at all. So it does seem to be a rather a practice variation between hospitals that accounts for this. Now, coming back to what Porter and Iceberg in the book argue, they argue that that much of this practice variation and overtreatment is caused caused by the fact that payment is not based on what patients value. The strange thing is, of course, is that we do not pay for actually what we value, better health, the health outcomes, whether patients recover, or whether life expectancy is improved, or whether quality of life of patient is improved by the medical treatment, but rather by the frequency and the effort that physicians and hospitals have to provide in the treatment for us. So rather the payment is not so much based on what patients value, but rather on what physicians value, namely how much time and effort they put into their work. And that's most obvious with fee-for-services payment systems, which rewards quantity, which rewards how much and how frequently you do a certain form of treatment, how many patients that you treat, and does not reward the quality by which of the treatment that patients receive. It doesn't reward actually how well you do it, it only rewards how frequently, how often, and how many patients that you treat. And fee-for-services interventions are, of course, a major incentive to provide more treatment, to provide more interventions to patients, so to provide more diagnostics to patients. And the result of that is overtreatment of patients, and accounts for the practice variation that I showed in the previous slides. So what Porter and Iceberg argue is that there should be a shift in the healthcare system, a paradigm shift, you may say, towards payment and towards organization of the healthcare system organized around what patients value. And patient value they define as patient-relevant outcomes relative to the cost per patient to achieve these outcomes. So mainly it's an efficiency measure that looks at the inputs, the cost for treatment of the patient, but related to the outcome of the treatment provided. And the outcome of the treatment provided in generally and ultimately are, of course, whether it increases life expectancy of patients and improves quality of life of patients. Of course, there are lots of intermediate outcomes as well, but the ultimate outcomes are, I think, these two that I just mentioned. Porter and Iceberg argued that in order to achieve this, changes have to be made on 6 elements. The first is that you have to have an integrated perspective on the treatment of patients. Most healthcare systems make a distinction between outpatient care and primary care on the one hand, and secondary care or inpatient and inpatient care on the other hand. These primary and secondary care are frequently organized separately and differently. There's usually some, but not a lot, of communication and collaboration between primary and secondary care, and more importantly, reimbursement is separated between primary and secondary care And what they say is, well, rather than have these separate, fragmented elements in the system, you have to look at the integrated way and look at the integrated care for defined patient groups. That's also a separation. We usually have a payment that is, at least in primary care, that doesn't distinguish between patient groups, where primary care providers receive a reimbursement, which is more somewhat, but not always, related to the type of patients, the disease or the condition of the patient. And what they say, well, you have what Porter and Iceberg argue, we have to organize the treatment around the patient for a specific patient group. So we have to organize the care for cardiology patients separately, for cancer patients, different forms of cancer of patient differently, for patients with chronic diseases like diabetes or COPD, have to organize it separately. So organize care around clearly defined patient group. Secondly, it depends on data and knowledge about what patients value. It's important to measure outcomes in order to assess, of course, whether there's practice variation, and in order to redefine the system based on what patients value, you have to know what the outcomes are of the system. How well does a hospital perform in improving mortality for patients, or improving quality of life of patients. So you have to invest in data to measure outcomes and cost for patients in order to redefine the system. Also, the financing has to be organized around the patient, and no separate funding for primary and secondary care, no separation in funding between inpatient and outpatient care. Now, all the funding has to be integrated in a network financing where all care providers involved in the treatment of a patient with a certain condition has to be done through a form of network financing. And that not only involves the financing for medical providers, but can also involve financing for paramedical providers. Physiotherapists may be important for some forms of treatment, or if it comes to lifestyle changes, not only physiotherapists, but also, for example, dietitians may be important to achieve change in and improve outcomes for patients. So all that has to be integrated in a form of network financing. Related to that, of course, care has to be provided within a network of primary care providers, paramedic providers if necessary, hospital providers, but also in a network of hospitals that work together in a network. Of course, that it's also based on expanding best practices, that what is achieved in one hospital in improving outcomes is also applied in other hospitals. That's a frequent limitation, the not invented here syndrome, where hospitals are unwilling to take over good practices from other hospitals simply because it's not developed or invented by themselves, and they're reluctant to accept advice and best practices from other hospitals. And all of this, of course, cannot be done without sufficient IT technology, without the data, both the data and the technology to use these data and to provide knowledge from this data. So ICT and data are important supportive technologies in that. Now we see that around the world this has gained quite a lot of attention and initiatives to redesign the healthcare system towards patient-centered care, and that involves most obvious elements of that is that hospitals work towards measuring patient-relevant outcome measures, and that I think in general can be distinguished in collecting data about clinical outcomes around patients, or relevant clinical outcomes for patients, and collecting data about what patients value and what patients' experience have been through PREMs, patient-reported experience measures, and PROMs, patient-reported outcome measures, to more directly also assess what patients have experienced and what outcomes they have seen of the treatment they have received. So that is, I think, one element, a huge movement towards collecting more data among outcomes, and also more collaboration, development of networks of care between hospitals within a network, between referral hospitals, between general hospitals and academic hospitals, for example, but also between hospitals, which also is associated with more specialization of hospitals. I think one trend that has also been set in motion by this way of thinking is that hospitals become more specialize themselves more in the activities in which they can excel, and in the areas where they do not really excel, they leave to other hospitals, and the way to provide treatment is then to collaborate within a network in which every hospital specializes in the areas in which it is best and can excel the most. Also, collaborations in networks between hospitals and primary care providers and other providers, as I've mentioned, like paramedical care, but also mental health care providers, which also may play a role in contributing to patient-relevant outcomes and experiences in with the system. Another consequence has been mainly, of course, with the data collection on patient preferences and outcomes, is collecting data, the use of data, the application of data analytics, in order to transfer all this data also in patient support tools for shared decision making. So it's of course you need to collect data, but data only become meaningful if you use them in one way or another. And there are two ways in which these in this situation are being used. One is to compare performances of hospitals or healthcare providers on the one hand, so in order to make more transparent what providers achieve, and on the other hand, as a support tool for patients in shared decision making, and where patients and physicians can discuss the expected outcomes of alternative treatment paths, and that based on the data on the clinical outcomes and the PREMs and the PROMs, patients can say, well, if we take this way of treatment, the expected outcomes are like this, but if we take an alternative way of treating, then the outcomes are likely to be like that. So it's also helped to develop decision support tools, and in many areas you now see that patients can use these tools in order to discuss with the treatment provider well, what their most preferred option for treatment is. And finally, although this is that is at least I think in the last stage, it's also good to develop payment models that incentivizes these developments towards value-based healthcare, to more outcome-related focus of the healthcare systems. And the payment models for value-based healthcare in general, I think they're twofold. There are two types that are distinguished and that also are being introduced. One is forms of bundled payments, a form of integrated payment for all providers involved in the treatment of a specific patient categories, patient group, disease category, and outcome-related payment models on the other hand, which provides incentives or rewards the achievement of certain levels of performance, of outcome that have been achieved. Of course, both payments models can also be combined. There are also examples of bundled payment with bonuses or rewards for outcome targets to be that are achieved. Now, a bit closer look at these forms of payment. Bundled payment systems are a one-off for treatment, types of treatment with a specific end date, where a patient has been cured or the treatment is finalized. Or periodic for more chronic diseases, which requires long-term forms of care. So one-off or periodic lump sum or integrated payment for all services provided for a specific patient category. And these payments are based on evidence, on best practices, and defined by clinical pathways that are developed based on these best practices, also with an emphasis on the outcomes that have been achieved. Now, as I said, these bundled payment systems, where you have one form of payment for a patient type, and then within the network of care, the allocation to the different healthcare providers involved for the care of patients is decided upon. So mostly the decision who gets what on the treatment of patients is decided within the network and not outside the network by the structure of the payment system is a critical element of these bundled payment systems. And these can also be, of course, combined with some forms of reward for achieved health outcomes by shared savings or shared risk components, where part of on top of the bundled payment, providers can get an extra bonus if they meet certain performance outcomes achieved. For example, a decrease in mortality rate of patients, or a shared savings if they are able to achieve certain outcomes, but with less of the payment than they receive, that they can keep these the difference between the actual payments and the real cost as a form of a shared savings model. Now, as I said, there are two types of bundled payment: episode-based for acute forms of care or elective care activities, and periodic-based for patients with chronic diseases which receive treatment over multiple years without a specific end date for the treatment being defined. These can take different forms, and the strength of these bundled payments models is that it shifts the accountability to a group of healthcare providers, and that within the network they not only decide on who does what and how intensive the involvement of providers is with the treatment of patients, how much is done by general practitioners on the one hand, how much is done by within the hospital by medical specialists on the other hand, that they shift most of these responsibilities to the network itself, but also that they become more accountable as a group, as a network, for the finances and the clinical outcomes that they achieve, and they provide accountability to the payer in the system, the insurance company or the national health system in other countries. Now, it's an incentive to coordinate care in the best possible way for patients within the network, and also to improve collaboration within the network. Of course, one of the inefficiencies in the network is frequently done caused by lack of collaboration, which, for example, leads to diagnostics being done multiple times for the patients, which has caused that information is not shared between providers, which may be detrimental to patients. Now, it also provides more incentive to coordinate care between all people, providers involved in the care for patients. And it offers flexibility to provide care in different ways. Now, the outcome-related models, they rely on outcome indicators, where part of the reimbursement is dependent on achieved health outcomes. And that can be, for example, a reduction in mortality rate, or in the reduction in the percentage of patients that need retreatment, but it can also be, for example, the reduction in the waiting times for patients, or the reduction in the number of times, for example, emergency wards are being closed for new patients. So outcomes can be defined in different ways. Doesn't necessarily have to be clinical outcomes to patients, but also can be more process-related outcomes that also matter to patients. Now, the main goal of this is that it provides an incentive for providers to improve themselves on these outcomes, to improve mortality rates, or to reduce waiting times for patients, and that by rewarding this, that you provide incentives for them to improve themselves on that. So one, of course, requirement is that these measures have to be measurable. They have to be measured in an objective way, and they can be the reward system can either be bonuses for positive outcomes achieved, but also can have penalties, or can have both. That you have a two-way sided risk in which they receive a bonus if they achieve a certain outcome, but get a penalty if they score highly negative on this same outcome. They can be specific to a specific provider, depending on the areas in which the provider can improve itself. It can be targeting one hospital, one form of treatment, can be for a specific primary care physician. And it can be in specific areas. It can be in cardiovascular care, but also can be in cancer care. You can have outcome-related payment models in one area, but not in the other. And they can be from one to improve in one outcome area, but not on other outcome areas. So it can be very much targeted to where you think that improvements is most needed and best achievable. Now, there's also diversity. That you can also, in the payment models, it can be that there are also combinations between the forms of bundled payments and shared savings incentives, but also with global budgets and shared savings. The flexibility also includes that you can design it in different ways, which best meets the targets that you have with your system. And it can also target multidisciplinary provider groups. It doesn't necessarily have to be hospitals or physicians, but it can also involve other providers involved in the treatment for the patients. And it can be done for different forms of care. Now, some examples to illustrate this. These are some examples that have been developed in the Netherlands, where in a network of care, for example, of some hospitals and general practitioners in the east part of the country, part of the reimbursement is made dependent on the mortality rate or the survival rate of patients and on the retreatment. And the hospital receives a bonus, an extra amount of money, if it's able to bring the mortality rate for cardiovascular patients below a certain level, and the same if it is able to reduce the retreatment rate before a predefined and negotiated level of treatment. And that has made these hospitals more focused on reducing mortality and retreatment rates. Another example is a large hospital in the Western metropolitan area of the Netherlands, in which the reimbursement for the emergency care of hospitals was made dependent, or partly dependent, on the number of closings of the emergency care, the waiting times for patients in the emergency rooms, and patient satisfaction. So based on surveys among patients who had used emergency care about the satisfaction with the treatment that they received in the emergency care, that was also part of the hospital could receive a bonus if patient satisfaction was above a certain level that was negotiated with the insurance company. Now, of course, no reimbursement system is ideal. There are always, of course, disadvantages or caveats that you have to make with any reimbursement model. I think there are a number also involved with these forms of value-based payment models. One is the administrative burden. Of course, if you define payment systems around the patient category, then for each patient category you have to make separate arrangements about the payment, and within the system also about the division of resources, and that can, of course, create additional administrative cost and impose the administrative burden. Also, the administrative burden may be increased because of all the data collection that you do, where not only patients but also healthcare providers have to report about the outcomes and the use of shared decision, and that can also lead to a significant increase in the administrative burden. Second caveat, I think, is all these forms of value-based payment are very much dependent on the commitment of staff. Staff, all providers involved in the treatment have to agree on working within the network and to agree with the arrangements within the network about the division of tasks in the treatment of patients, and also in the division of resources for that. And that requires quite a lot of commitment and support and consensus to achieve that. And that is also, sometimes an obstacle to really achieve these forms of value-based healthcare. And finally, this becomes more complicated the more stakeholders are involved in this, because that not only complicates the consensus to be reached, but also increases the administrative cost and the administration that is involved with this. Other problems is that not always outcomes can be influenced. A precondition of this is, of course, that the outcomes that you reward have to be can be influenced by the treatment that is provided, by the provision of care, and that's not always the case. Of course, there's always a random element in that, and sometimes outcomes cannot be influenced. So that's also an obstacle in developing these sort of systems. And finally, of course, the availability of data, and not only in the collection of data, but mostly also in sharing these data. What you see in practice is that hospitals or healthcare providers are not always willing to share data with others, especially, of course, not if the data show that they are not performing so very well on these outcomes. So mostly in the cases where you think it's most needed, parties may be most reluctant to make data available for others and for use within these models. Okay, this is what I had prepared for you. I think it's interesting to reflect and think about value-based healthcare models. also especially in a situation of reform as is now in the Ukrainian healthcare system, which provides, I think, also opportunities for more integrated care, especially I think between primary care and secondary care. If I look as an outsider to the ongoing reforms, I think it's quite it's focused, firstly focused on primary care, now also on secondary care, but not so much on the integration between primary and secondary care. And I think there's a lot to be achieved and a lot to be gained by looking at this integration as well. Okay, that's it. Thank you.
Thank you, Wim. Any questions? While you're thinking of the question, I will ask one. So here today we have the distinguished audience of our scientific community you've also been working with, but they mainly represent the educational institutions, medical educational institutions. What would you say how this value-based models and approach impacts the curriculum and the education of healthcare professionals?
Now, it all starts, of course, by training of medical professionals, by training of doctors. What I think in the lessons learned from this for medical training, I think, are multifold. One is more emphasis on collaboration. I think that's not always evident in the medical training, that as a physician you in a hospital you collaborate with the GP, for example, but also with paramedic providers, with physiotherapists, with nurses. I didn't mention nurses so much, but nurses play an important role in the whole value-based healthcare system as well. And of course, usually, frequently, nurses have much more intensive contacts with patients and longer contacts with patients than for example, the physicians has. So it also involves a different way in which the physicians see themselves within the system. It's not for nothing that I said it's a move from a physician-centered system to a patient-centered system. And that requires a different attitude to begin with from physicians as well. And the change in attitude of physicians starts with medical education. So I think that is one lesson. Second is the role of shared decision making. We have one project which I was fortunate to supervise about communication skills of physicians. Now, one area, the most important area, is of course in the communication with the patient. And I think one change in attitude is that you listen to the patient, that you discuss with the patient what the patient really finds important and values in his treatment, and base your treatment actually on the values of the patient. And that requires a lot from the communication skills that physicians have. Now, I think these are at least two areas. I think also a bit broader perspective on patients. Patients not always find it important that they receive an operation, that they receive treatment. No, patients may value that they're able to talk to their grandchildren, that they are able to care for their garden after, and it's also so these wider, not just the focus on the medical technology, but the value of what it means for patients and what patients really want and what they prefer in their daily life. And that also, I think, makes it, requires a shift, a paradigm shift in physicians, and that is also, I think, important to include in the medical education.
Let me get it if I got it right. So it means the shift, like in previous century, let's put it this way, we were paying more attention towards, let's find out about like how the system works, how the body works, and it was heavily in medical education curricula on the body. but here is more about the more social aspect of the healthcare, more soft skills within the medical team, and more communication with the patient.
Yeah, that becomes more important, and finding out more what the patient. Let's give us an example. Let's take myself. I see many elderly people need orthopedic surgery, hip replacement or so. Then you can ask yourself, a hip replacement can be invasive at some point. Can be quite burdensome, especially at a relatively older age. Then the question is it always necessary to do so? I mean, if I value that I go out and make a walk every day for half an hour, then it may be important to have a hip replacement. But if I'm someone who likes to sit in a chair and read if I'm old, then maybe a hip replacement may be not so much important than maybe other measures that to ease the pain and so on, that may be more relevant and more valuable to a patient. Now, what value-based healthcare involves is that you ask the patient, what do you want from your life? What do you find important in your life? And that we make the treatment conditional on achieving that, and not that we say, oh, we see here that you have pain here, and that you have a corrosion of your hip, and you need a hip replacement. And not a narrow medical focus on what medically, technologically possible, but to look at what patients really want from life.
Thank you very much. While you're thinking of the questions, I will just quick comment that in parallel in the next door room we have a training for primary healthcare professionals on this is managerial and communication training for them. So partially what you're saying on the primary healthcare level, we as the Ukrainian Swiss project medical education development already do, and this is one of the steps that we are doing in this direction. And I saw a couple of hands. The first one.
Thank you for a very interesting presentation. And what I want to, maybe not to ask, but to reflect, that in Ukraine we are not very used to work in such implemented models. And sometimes for us as medical educators, it is a problem, yes, what for do we have to prepare our students? Yes, so which models that they will work in? And so what I really agree that it is important that we will implement competencies, and you know that competencies, they include not only knowledge, but skills which will be relevant for specific practice and attitudes, yes? And I think if we will understand these models and when we will develop attitudes in our students, when coming to the practice, they will be ready to implement these new approaches and new models into healthcare.
Yeah, I agree with that. With one emphasis, it's not so much to implement them, it's more to develop them. I think what is important that you sit together and say, what is the best model to organize this? And can we reach consensus about it? It's also not the top-down that these models are developed and you say, you have to do this. No, it's bottom-up. You yourself and the physicians and also mostly, of course, I think you have to put your hope on the physicians that you educate and train, that they are willing to develop these sort of models, way of collaboration in the best interest of patients.
Good day to everyone. Firstly, really thank you, Wim, for this very interesting topic, very interesting information, and I really think that this topic may be interesting from position of view that for me, you said more about more humanistic medicine, more humanistic healthcare, not so practitioner, but more humanistic. And I think it's really in trend of changing in the world that we have at all last years. But from position of view of educator, I want to say that maybe here, firstly, continue question of Victor, we have to think not only only about include these questions, these skills, some point of this sphere in curricula of medical practitioner. But I think here we have second side, maybe. It's a side or level of managerial decision or maybe political decision. Because if we want to change this conceptual paradigma of healthcare and work with patient in healthcare, because here I think we have to talk about changing paradigma. It will be not enough work only with practitioner medicine. We have to change mention of managers in healthcare, and maybe we also have to influence on educational program for these specialists in future. Because really, if we talk about medicine now, maybe, and for Ukrainian and for other countries, it's not very interesting for medical managers change point of view that you said, because really benefits of medical institutions now depend on number of services. Maybe, I don't know, maybe like proposition, maybe what do you think about this? I think that here we have to also think about some, I don't know, maybe some governmental program or maybe some project to change this understanding of healthcare, meaning of healthcare, goals of healthcare on this level of manager. This. Thank you.
Yeah, I agree with what you're saying, Nina. I think it's a valuable addition to what I've been saying. Indeed, it involves the willingness and the involvement of everyone involved in this, including managerials, including, say, political, facilitation that facilitates these forms of development. So it's important to have these on board and to support this as well. But I do think that the lead should be taken by physicians. Physicians, I think, are initially best able to identify where improvements are possible. Where in the process of treatment of the patient can you improve yourself? And in discussion with patients, what outcomes are important to emphasize and to improve. I think it's important. I think to say it's more a bottom up with physicians and patients in the lead, and managers and politicians should follow on this.
You actually answered my questions that I would like to jump in, where the change starts. Because we have quite a complex system. It's more than 500,000 people involved in Ukraine. I mean, involved in the healthcare provision, the education. It's a large system. It's more than Luxembourg. It's more people than lives in Luxembourg, and it's huge. And you answered that it starts with the physician. And physician formed and shaped in your classroom. So this is like what we're talking about, that in classroom we start in this change that will have a snowball effect, if I got you right.
Yeah, indeed, yeah. And it starts locally. I mean, it's not that you have to impose it. That's also not part of bottom-up. It starts locally. It starts with physicians who think from a professional attitude and the professional norms that they have, we want to improve the care that we provide for patients. And how can we best do that?
Thank you. While you think on the question, I have another one. You showed a lot of data, and it shows that, first of all, you have the data and the access to data on a scale of the Netherlands, of the EU, of the OECD. We partially missing some data due to some imperfections of the IT solutions that we have. Due to the martial law, we don't have all the data published now. So back in the days when you had limited data, how did you do your researchers on health economics or health services?
They are very limited. I mean, then there were limited possibilities to develop these things and to gain insight. So indeed, the collection of data, the setting up patient registration data, for example, that I think something that is important to do nationally, to have registration data for different types of patients. Collect data in hospitals among patients about their experiences and the outcomes that they perceive. These are, of course, things that have to be done in parallel to collaboration within and setting up networks of care. And I mean, I fully understand all the problems and the barriers to implement that. But of course, in Western European countries, this is far from being done as well. I mean, there's a lot to be done in my own country, in the Netherlands, in this area as well. And it's also not something that where improvements have been made, that it's been achieved overnight. That has taken years to achieve this. But what is important, I think, that to set this in motion, to have these these front runners that want to take the initiative to make the system more patient-centered. And I think, indeed, like you said as well, we have to put our hopes in this on the younger generations who are able and willing to do so. And for that, I think, again, medical education reform and training is utmost important.
Thank you very much. I'm here with the educators community. I'm hearing quite a lot that we're so tired of the reforms. Like every minister comes, they offer or they think they offer a reform. Every minister of education, every minister of healthcare. So every year or a couple times a year, it's like a new reform brand. From your experience in the Netherlands, how often do you experience this systemic change or a policy shift in education and specifically in medical education?
Now, I think there's one more major reform that is needed in the healthcare sector in Ukraine. If, as an outsider, I may give some advice, and that is make yourself less dependent on the Ministry of Health. I think, indeed, what I see here, I come here now for more than 20 years, is that there's always look up. What does the ministry say? Indeed, these ministers change every 6 months, and every time there's someone else, and then they have someone else to complain to, because you see, my outsider assessment is that on the one hand, people here very much look up to the ministers. You should say what we should do, and on the other hand, they always complain about what they are actually doing. And I think the main thing is, and I think that's also part of, I'm going to discuss this in the other presentation I'm going to give, is that part of the EU reforms will be that the move towards more autonomy of institutions in Ukraine, including healthcare institutions and universities. And that will make that you have to look less towards the ministry for guidance on this and take more initiative yourself and develop that. And I think, what I've said, I've mentioned not for nothing a couple of times, this is a bottom-up movement. This has to come from professionals themselves, stemming from their professional attitude and norms that they have, and you should not wait for the ministry to put a law implementing this, because that's not going to work.
Thank you. Questions? Based on the presentation, or you know Wim from like his publications and other events, and he's been supervising you for more than half a year?
That's also why I think it's so important to come back why we're here for today and tomorrow. Why these research projects that are so important? Because research also gives you the tools and the knowledge that provides the basis for actual change. And I think if you have the skills and also I think the enthusiasm, which I hope we have created with these projects to do research, then this research can be form the basis of actual change in that was also the aim of each of the projects, to make some change in the curriculum, and that hopefully will result in a change in the students, and that they will take over in their professional career to take more the lead in the reforms and the changes.
Thank you. If you do not have any questions, before we will have a coffee break, I will ask you that another part of the title that you have is the Professor of Evidence-Based Education. We are fans and followers, I don't know, admirers of evidence-based medicine. Could you give us an example what, or like not the definition, but like usage and application of what evidence-based education is, and how you as a professor and educator practice it?
No, yeah, everything we do in education are an intervention on students. So in that sense, it's not so much different from what the physician does. The only thing is we don't cut in our students, of course. We don't drug them. But what we do is we provide interventions on students. Another thing, the interventions that we apply on students may be much more impactful for the lives of students than maybe what a GP or a physician does. What you learn in school and at university has lifelong lasting effects on your prospects in life, on how you perceive the world, what your capabilities are, and how successful you are, not only in your professional career, but also outside your profession. We know that education is associated with almost everything that we value in life, including a good health. Higher educated have a longer life expectancy and can look forward to many more years in good health than lower educated. So the impact of education, especially good education, is much more substantial than what we do in the healthcare sector. So then it's also of utmost importance that what we do on our students, the interventions that we apply on our students, that we know that we achieve the intended outcome. And for that we need evidence. We need to know that all these interventions, the way that we teach, the design of the curriculum, the way we interact with our students, what the effects of that are. And that is essentially what evidence-based education is about. Look what works in education, and how we can get the best possible outcome for students of the educational interventions that we provide.
And maybe to add here, this value-based approach that you described in your presentation in healthcare, also worth mentioning in education, like knowing how your student, there it was patient and here is student, how like what effect it will have for a student. So from your answer, I understand that not only doctors, physicians playing God when they do the surgery, but also the educators, they playing gods when they are in classroom, when they interact with their students. Thank you very much for this insightful plenary session. We'll not let you go back yet, because we have today still the panel discussion about the publications and what kind of publications you prefer. I'll ask you later in the evening, and tomorrow we'll talk about what to expect from the EU regulations and policies in education. Thank you, Wim. Thank you all. We have half an hour